Welcome to Practice Medical Cases with MedicoMedics. Before we dive in, if you want more high-yield, practical, clinical cases just like this one, please make sure to drop a comment below. This video is part of our new experimental high-yield practice medicine playlist. It is designed to sharpen your USMLE and clinical thinking in just minutes. And for every 10 comments to our video, we will post another question, and we will keep going until we hit 1,000 questions. So hit that like button, leave a comment, and join the journey, one case at a time. A 28-year-old woman presents with chronic diarrhea, bloating, and weight loss. She reports fatigue and occasional abdominal cramping after meals. Physical examination reveals pallor and a mildly distended abdomen. Laboratory studies show hemoglobin at 10.1, mean corpuscular volume at 72. Tissue transglutaminase immunoglobulin antibodies is positive. Total serum immunoglobulin A is normal. Duodenal biopsy reveals villus atrophy with crypt hyperplasia and increased intraepithelial lymphocytes. Now, which of the following best explains the pathophysiology underlying this patient's disease? Please feel free to pause the video and read the alternatives. If you've selected B, then you are correct. It's immune-mediated damage triggered by dietary gliadin in genetically predisposed individuals. Now, celiac disease is a T-cell mediated autoimmune disorder of the small intestine triggered by exposure to gliadin, which is a component of gluten. In genetically susceptible individuals, especially those with HLA-DQ2 or HLA-DQ8, gliadin is deamidated by tissue transglutaminase in the lamina propria. Now you can see the pathophysiology in this illustration. You can also check our dedicated lecture on celiac disease in our pathology series. But what happens then is the deamidated gliadin is then presented by antigen-presenting cells on HLA-DQ2 and 8 molecules, leading to the activation of CD4 T helper cells. These release inflammatory cytokines. And this is the process that leads to villus atrophy, crypt hyperplasia, increased intraepithelial lymphocytes, etc. So these mucosal changes impair nutrient absorption and lead to symptoms like diarrhea, weight loss, bloating, and iron deficiency anemia. And this is due to impaired iron absorption in the proximal small intestine. The pseudomembrane biopsy findings and positive anti-tTG immunoglobulin A antibody support the diagnosis. Now, why is it not A? Well, autoimmune destruction of parietal cells leading to impaired vitamin B12 absorption. This describes pernicious anemia, which is an autoimmune gastritis targeting parietal cells, leading to loss of intrinsic factor and therefore B12 deficiency. So it's unrelated to gliadin or small bowel villus damage. What about alternative C? So inhibition of brush border disaccharide ACE activity leading to osmotic diarrhea. Well, this describes lactase deficiency actually, where lactose is not broken down in the small intestine, leading to osmotic diarrhea and bloating. So, difference is there is no immune involvement or villus atrophy here. What about D? Inflammatory destruction of colonic crypts with neutrophilic infiltrate. Well, this is classic for ulcerative colitis, which affects the colon, not the small intestine. So it's incorrect in location and in pathology. And finally, granulomatous inflammation causing transmural intestinal wall damage. Well, this describes Crohn's disease, which causes transmural inflammation and non-caseating granulomas anywhere in the GI tract. So celiac disease is a mucosal level small bowel disorder compared to Crohn's disease. Now let's briefly review celiac. So again, celiac disease is an autoimmune reaction triggered by gliadin, specifically the gliadin component, while it's triggered by gluten, specifically the gliadin component. And it's triggered in people who are genetically predisposed. It's strongly linked to HLA-DQ2 and DQ8 alleles. So when gluten is ingested from wheat, barley, or rye, it then activates our T cells, leading to inflammation and villous atrophy in the small intestine. What are the classic symptoms? Chronic diarrhea, steatorrhea, bloating, flatulence, weight loss, iron deficiency anemia, for example, due to malabsorption, deficiencies in fat-soluble vitamins, and a hallmark skin finding, which is dermatitis herpetiformis. So itchy blisters from immunoglobulin A deposits on the skin. Looking at diagnoses then. So positive anti-tTG immunoglobulin A antibodies, which we saw up here. The test was positive. Or another diagnostic criteria could be anti-DGP immunoglobulin G if the patient is immunoglobulin A deficient. Furthermore, small bowel biopsy showing villous atrophy, crypt hyperplasia, increased intraepithelial lymphocytes, for example. Also, don't forget to check total immunoglobulin A levels to avoid a false negative. Moving to treatment of celiac, a strict lifelong gluten-free diet. That's it. Furthermore, you can also replenish nutrients, especially iron, calcium, vitamins, of course, and monitor for long-term risks like T-cell lymphomas or osteoporosis, etc. Anything that could follow from loss of important nutrients. Prevention, well, there is no true prevention, but early diagnoses and dietary control can definitely prevent complications and improve quality of life. And that's it. And that's the end. Hope you found it interesting and insightful. And please remember, for every 10 comments to our video, we will post another question. We will keep going until we hit 1,000 questions on our playlist. Also, don't forget, for more easy-to-understand lectures, please visit our channel and check out our playlists. We post new videos every day. Until next time, keep it clinical.